Okay, now if you have a deficiency of T3 and T4. So this is the second most common endocrine disease next to diabetes mellitus. All right, like I always tell people, make sure you understand all the things that are most common. These are the things that are going to pop up on your NCLEX. They want to make sure you are comfortable and you're knowledgeable on the common things, because these are the things coming into the hospital and doctor's offices. So they're going to have a lot of questions about these. So females have it more than males, and again, it doesn't really affect the calcitonin. This is hypothyroidism. Now here's where it gets a little confusing. It's also called myxedema. Now, like I said, a sign of Graves' disease is pretibial myxedema, which is this edematous, dried skin in front of the shin. This hypothyroidism is called myxedema because it's not just on the skin in front of the shin, it's the whole body. But it's very subtle. You'll see, I'll show you pictures. It could be your next door neighbor, okay? It's not so gross as what you saw before, but their skin is very thick, and you'll see what I'm saying. So we could have primary hypothyroidism. In this case, this is where the thyroid, the source, is actually secreting less T3 and T4. Or we can have secondary hypothyroidism, just the way we did hyperthyroidism, is that the anterior pituitary, for some reason, is secreting less TSH, which means there's going to be less T3 and T4 from the gland. And we also have, similarly, iatrogenic, well, that's wrong. It's iatrogenic I got to fix that. Iatrogenic hypothyroidism. This is wrong, okay? But iatrogenic hypothyroidism is the most common for this to happen is treatment of hyperthyroidism. Okay? So basically, if someone's got thyroid cancer, they need to remove the thyroid. Well, if you remove it, that means T3 and T4 is not coming out. And that means that that person's going to be hypothyroidism due to some medical treatment. That's why we call it iatrogenic. Okay? Does that make sense? All right? So again, sorry about that. That's iatrogenic hypo that's in blue. Okay? The treatment of hyper, that's correct. But the one in blue should be hypothyroidism. Okay? All right. So if you have a decrease of T3 and T4, that means your metabolism is going to decrease. So you're going to have opposite effects of hyperthyroidism. So you're going to have bradycardia. What does that mean? Slow heart rate. In fact, less than 60 beats per minute. So cardia means heartbeat, brady means slow. You get constipation. Why will you get constipation? Think back to why you would get diarrhea in hyperthyroidism, which is the opposite. Right. The stool, right, the feces in hyperthyroidism, the intestines, the smooth muscles, is just going to squeeze and do peristalsis to push everything out so that the water can't get absorbed. So that's why water stays in your stool. In this case, the stool stays, or the feces stays in your stool longer because it's going to take, the smooth muscle is not going to squeeze as much. So there's a longer amount of time that water can actually get absorbed. Does that make sense? So now the feces is going to be very dry, and it's going to take longer for it to move along with peristalsis. Okay? You'll get, remember, you decrease your metabolism. You're going to weight gain, obesity, cold intolerance. It's 100 degrees. I know, but I'm cold. Right? That's what that is. Skin, like I said, gets thickened, edematous, and dry. Their hair starts to be very brittle, starts to fall out, okay? Very dry. Even their eyebrows, they start falling out too. They get decreased libido, right? Decreased sex drive, very tired all the time, and depressed. So this is where it comes in, right? If someone comes in and they look depressed, they sound depressed, first thing doctors and nurse practitioners want to do, all right, we'll give you the antidepressants. It's very common. It's not going to help here. You're not treating for the right thing. So in a workup for someone who's got diabetes, they're going to put in T3 and T4. Because that could be the reason. Again, you've got to treat the disease. If you just treat the symptoms, that's not going to work. Right? You can't just treat the headache and realize that he has a brain tumor. That's not going to do anything. The depression may be, generally might be, severe depression just from the brain itself, right? Just certain kind of neurotransmitters not being released, serotonin and stuff. Or it could be a symptom of this. If you treat if this person has myxedema, you treat the myxedema, the depression will go away. You're treating the right thing. Okay? All right, so that's a little bit about that. Okay? And here's different signs and symptoms of myxedema, all the stuff we kind of talked about. And this looks like in your next door neighbor. Maybe not yours, but what I'm saying is you see a lot of this, right? Their hair is thinning. Look at the eyebrows, they're kind of falling out. The skin itself is thickened, edematous. You see this a lot. Not just that. Now, it could be just getting older, too, you know. So that's basically what's happening. Okay? Now, let's talk about Hashimoto's thyroiditis. Hashimoto's thyroiditis. This is also another form of hypothyroidism, and it's chronic inflammation and progressive destruction of the thyroid. This is an autoimmune disease as Graves' disease is, but it does something different. What happens here is that in Hashimoto's, it's similar to here. What's going to happen is it's going to look like something else, but then down here, it'll look like the same thing that we've been dealing with. It's got the same configuration that's going to fit right in there. So what's going to happen in Hashimoto's is that this is going to go right into here, but it plugs it. This goes in here and turns it on. This goes in here, and TSH can't get there. It blocks this. So in other words, Graves' disease goes in here and turns it on. Hashimoto's autoimmune disease, it goes in here and turns it off. Does that make sense? All right? You just go here, and it's plugging it so that TSH can't even get on it. TSH can turn this on. But this is now blocking that. So this is going to go in here and turn off. So therefore, T3 and T4 don't come out. Now, there's different stages that happens over here. At first, when this happens, this thyroid gets inflamed. All right? It's kind of like going into shock and realizing we need TSH over here. So it becomes a little bit bigger, trying to make almost like a bigger net. It wants to try and find any TSHs that are on there, but it's not working. So this actually becomes a goiter for about a couple months. It gets big. We miss out on that, though. Most people don't realize that it got big because then it just shrinks. So at first what's happening is it's an inflamed thyroid that grows for a couple months or so, and then it realizes TSH is not going to be on there, so it starts shriveling, and it turns into a scarred area, almost like what multiple sclerosis is happening. That it starts turning into scarred areas like it's an autoimmune disease. So it becomes a scar tissue, and the thyroid itself becomes very small, and it doesn't function. Okay? And that's what we call Hashimoto's thyroiditis. And the other thing about this is that people who have this have an increased risk of having non-Hodgkin's lymphoma. So it's important to figure out, all right, their T3 and T4 are low, we got to find out the reason why. Because if it's Hashimoto's thyroiditis, then we have to make sure that they don't have any kind of lymphoma. Okay, so they got to do a few more steps on it. Okay, and Oprah Winfrey, yeah, she has Hashimoto's. All right, she's probably had it for quite a long time, but she came open about it a few years ago. Okay, so that's what that is. All right, questions on that? All right, cretinism is also another form of hypothyroidism, but this is congenital hypothyroidism. Here's someone that is born that doesn't produce any T3 and T4. It's congenital. Now, we don't worry about it so much. Well, we don't see it as much because every baby that's born gets tested with this before they go home. Just the way we do PKU. Okay? okay? There's a brigade of tests that they do. If you ever had a baby and they're doing all these tests, these are some of the tests. They do a hearing test. They do all these brigade of tests. So what happens here is that if they find out that there's no T3, T3, and T4, it's an easy fix. They're going to be on Synthroid, that synthetic thyroid medication, for the rest of their life. So they're not going to die. They'll just have to take a pill for the rest of their life. Big deal, right? You got a nice, they'll live, they'll be a doctor, nurse, whatever they want to be. They'll just have to take this for the rest of their life. Now, it's important that they test them before they go home, because it is an irreversible thing if it goes too longer than, I think, like once it reaches like 4 or 5 years old, it's irreversible. So we have to fix it. You get dwarfism. Why? Because we understand that T3 and T4 is important in growth, as much as growth hormone and the sex steroids and stuff. You also get protruding tongue, lack of hair and teeth, pot belly. I'll show you some pictures of this. But they get mental retardation. The thing is, you really are not going to see this until what? Maybe 3 years old? And maybe at that time it's too late. You may not get these over here, but you may get this. But you might not see this until 3 years later when it's irreversible. That's why it's important that they do the test before they go home. Because you don't want to have this growing or not growing and continuing, and then it gets too late. You had a question, Kevin?
So, I know that, mental retardation is not visible until, infants start developing their motor skills and their speech skills. So, with most of these symptoms, obviously not the pot belly, the protruding tongue, and lack of hair and teeth. But, is that why it's so important? Because mental retardation is not visible until you're at least 2 to 3?
Yeah, that's the whole thing. You won't see it later on. These you can see pick up earlier, but sometimes they can be very subtle. Maybe you had a small case, or maybe a little bit of T3 and T4 come out. But if they go home, you'll never know until there's the reason why. It's a mental retardation, or that's how they pick it up. So they look like this. Here's the other signs and symptoms. And it looks like this. The tongue is protruding, all right, dwarfism, all right. But we don't see it in America because everyone gets tested and they get treated for it. Okay, does that make sense? Otherwise, if it stays like this, it's going to turn into this. Okay? All right, so let's talk briefly about thyroid tumors. Okay, thyroid tumors, there's 3 I want you to really know. One is called papillary carcinoma. All right, this is the most common one. And luckily, when we think of thyroid tumors, I'm not saying they're not cancerous, but they're the, I know it sounds bad, but they're the better of the cancers because most of them are going to be slow growing. 85% of them are papillary carcinoma. And it's a very slow growing tumor. So we could pick up it early and get rid of it. And it's a pretty good prognosis. So that's why, they're concerned. You feel something in the throat, that there's an enlargement over there. People worried about throat cancer or their thyroid cancer. Yes, you should be. But you got to be able to nip it in the bud fast. Okay? We also have follicular carcinoma, and that's about another 10%. Now this can be pretty bad. So that's important. So you feel a lump in the thyroid, you got to determine which one is which. Hopefully it's this, because there's a good prognosis and we can treat it. But you don't want this. These invade the blood vessels and metastasize quite rapidly, very aggressive. All right, so these usually, if they metastasize, you got a poor prognosis. We also have another one called medullary carcinoma, and this one is a tumor, a malignant tumor that comes from the source of where calcitonin comes out. They come from the parafollicular cells. Now, this one, surprisingly, even though it secretes calcitonin, the calcium doesn't get so affected. So we wouldn't pick up on the calcitonin, what does calcitonin do to calcium? Decrease or increase? Tones it down, so it decreases, right? So surprisingly, the calcium levels don't get affected with this. Okay? It's pretty aggressive, just the way follicular carcinoma is. If it metastasizes, it's got a poor prognosis. Okay?